Welcome to EADV Live. Today's topic, the integration of digital photos and Mohs Micrographic surgery. I'm Christopher Horskamp, and on behalf of the EADV, we welcome you to today's interactive webcast. If you have any questions or comments about the subject matter, send them in at any time during the presentation, and our presenters will do their best to address them at the end. Today, we are joined by 4 esteemed speakers. 3 are with us right now, including our moderator and speaker, Dr. Kai Munte. He is the former head of dermatologic surgery and Mohs surgery at the Erasmus MC in Rotterdam, and has performed more than 10,000 Mohs surgeries and still performs them at Erasmus MC, the Maasstad Hospital, and Mohs clinics. We are happy to have him with us and happy to hand over the webcast so he can introduce the other speakers.
Thank you very much, Christopher. I will start with my presentation. Integration of digital photographs in Mohs Micrographic surgery. So first, I must tell you that I have one conflict of interest because I'm helping Chipsoft to develop a digital file basing on photographs for Mohs Micrographic surgery, and to directly integrate this file into a healthcare file, but I'm getting no payment or other compensations for this work. First of all, I want to mention the principles of micrographic surgery. Then I want to point out the Rotterdam digital innovation. And last but not least, say something about the future in digital mapping. The principle of conventional surgery is that you take out a specimen, mostly in a fusiform excision, and then the technician will cut out pieces like a brass leaf method, so that the pathologist can look at the slides like this, and he will tell you, oh, it's a nodular basal cell carcinoma, and it is free of margins. The problem is that he sees only 0.4% of the resection margins. So in this direction, the cancer is missed. Very different is the principle of every form of micrographic surgery, where we look only at the resection margins, and then we can see quite clearly that here is cancer left, so we need a second round, in this case, to completely remove this tumor. There are different methods in micrographic surgery. On the one hand, we have the American model with frozen sections, which is very fast. Up to 5 rounds a day is no problem. Quality is strongly dependent on the technician, but the overall quality is less than paraffin sections. On the other hand, we have the German model with paraffin sections, provide normally better quality, fast histopathology in own hands, 16 hours, but still not fast enough for 2 rounds in 1 day. So if we compare conventional versus micrographic controlled surgery, we can point out that micrographic surgery is radical surgery, whereas it's trying to be radical with bigger margins for conventional surgery. It's also tissue sparing, and everything is evidence-based. Still, micrographic surgery is no panacea. Why we don't reach the 100%. The tumor recurrence is mainly caused by incorrect interpretation of the histopathology, loss in orientation during the surgical procedure, or bad slide quality. Then to point out the Rotterdam innovation, because we are integrating the Mohs file into digital files with photographs, which creates a more realistic view, a more reliable backup, and in my opinion, it's a much better surgical documentation. And right now, almost 90% of all micrographic surgery performed in the Netherlands is performed in this manner. Of course, you need a computer in every operation room, and you need also a computer in the microscope room. Camera, which one you use is not important. Important is that you trying to take the pictures in the same angle at the same distance every time. If we look at conventional Mohs surgery, you compare the wound with a paper sheet. In the United States, they use normally same scale drawings of the wound. In the Netherlands, we had drawings on pre-printed forms. So the hard and software you are needing for this digital system, no fancy stuff needed. Normally, we use Microsoft Word or PowerPoint. You have its operation room. Also, a memory card reader is necessary, but no fancy stuff is needed. And it must be connected to a server. If you have no server, you can start with a USB stick if you want to. This is an example of a digital Mohs file. Here are the tumor characteristics, operators, the patient mentioned right here, and this is a photograph taken prior to the operation. And in this case, we had 2 rounds to completely excise the tumor. You can see it right here, tumor left, so we need a second round in this direction. You can retrieve the data from the server, of course, and then you can click on a certain date, and then you will have all the patients who are operated on this day, and you can retrieve the data from this file if you want to. We published this in 2016 in the British Journal of Dermatology. In my opinion, the digital Mohs file will make Mohs micrographic surgery more popular. And we will integrate this digital Mohs file directly into a digital healthcare file. I want to show you an example in practice. And these following photographs are extracted from a digital Mohs file for this presentation, which is quite easy to do. We can see here the photograph prior to the operation. Here are again the characteristics, the operators, and the patient data. This is from the University Hospital. Okay, 1 round, 2 rounds needed. for 3-4 rounds needed. And eventually we needed 6 rounds to completely excise the tumor. This is, of course, a special case. It's not a normal basal cell carcinoma, and it was much bigger than previously expected. But you never could have excised this tumor without micrographic surgery. You can also add the pictures of the reconstruction to the digital Mohs file. So the future, there is already an integration of this system in a digital healthcare file. Still busy with Chipsoft. It's not true. We are finished right now, so we can start to integrate it in this system. The photos in the future will be taken maybe by a mobile phone, and we will have a much smoother operation with Bluetooth integration. Maybe in the future it's also possible to have it as a Google or iPhone app. And last but not least, I want to mention that Mohs micrographic surgery is not only for basal cell carcinoma, but has advantages on every kind of tumor. So this is the last one, example of our new digital healthcare file, Mohs file into the digital healthcare file. Ladies and gentlemen, thank you for your attention. If you have questions regarding the lecture, please comment it on the chat box. Our next speaker will be Professor Jürg Hafner. He is a hospital-based dermatologist, dermatologic surgeon, phlebologist, wound specialist from the University Hospital in Zurich, Switzerland. He exerts dermatologic surgery since 1994 and has built over the years an experienced team, particularly for oncological dermatologic surgery. For him, medical education is a matter of heart. He is a board member of the International Society of Dermatologic Surgery, as well as the Swiss Institute of Medical Education. And I can remember he was also the leading man of the Swiss Dermatologic Surgery Society. In this session, he will lecture on surgical repair of the auricle. So please proceed, Jürg.
Thank you so much, EADV, and thank you, Kai, for inviting me to give this lecture on surgical repair of the external ear of the auricle. I have no conflict of interest to declare concerning this matter and whatsoever. We start with some anatomy. When you look at the left-hand side picture, you will see the outer frame of the auricle, the crus, the superior helix, the inferior helix, and the lobule. Then the internal frame with the anthelix that subdivides into the superior and inferior crus, the tragus and the antitragus. And finally, the 4 cavities that are subdivided by these frames, the concha, the cymba, the triangular fossa, and the scapha. Blood supply essentially depends on the external carotid artery that goes straight upward and runs along the preauricular area and gives a superior branch to the superior helix and an inferior branch which is named posterior auricular artery. This perforates into the lobule, and the lobule has abundant vasculature, and from there it connects all through the helix via a helical rim artery to the superior auricular artery. Innervation is essentially can be subdivided into three areas. Most of the auricle is innervated by the greater auricular nerve, nervus auricularis magnus, and the minor occipital nerve. Both are branches from the cervical plexus. The crus helicis, part of the lobule, and the tragus, however, are innervated by the auricular-templar nerve, which is a branch of the mandibular nerve, which means it is actually a branch of the nervus trigeminus, of the trigeminal nerve. So the anterior third of the ear is actually innervated by the trigeminus nerve. And most of the auricle is innervated by the greater auricular nerve, which passes behind the ear, and the lesser occipital nerve. However, the conchal ball and part of the cimba are also innervated by the vagal nerve. This is very important to note because sometimes patients get sick when you do local anesthesia on the concha or on the cimba. This is the reason why we always infiltrate local anesthesia to these areas of the auricle from behind the auricle through the cartilage. So you can avoid heavy vagal reactions. First, we have to mention that all the four cavities of the auricle heal very well by secondary intention. However, we rarely do that because it requires much time and it can be accompanied by quite a bit of pain for the patients. So usually we actually do repair also of the cavities of the auricle. The pictures in the middle of the slide on the right-hand side, however, show you a case where we did not do any repair, any immediate repair. This was an elderly lady in whom the infiltrating basal cell carcinoma reached the bone. And she was so tired of surgery that we decided not to repair this large and deep defect, but to let it heal by secondary intention, because also this retroauricular fold somehow is a concave area of the face. And you see on the right-hand side how nicely this heals, but this takes 2 or 3 months to become like this. What we usually do when the cartilage is totally exposed and denuded from perichondrium is that we apply punch holes into the cartilage to allow vasculature from the backside, from the rear side skin to be exposed, and this allows a graft to take. This is a very easy and reliable technique to get higher taking rates of skin grafts to the auricle when you have to repair larger surfaces. You can even apply that in a wraparound fashion when the rear side and the anterior side, as well as the helix, are exposed. Now I get to helical rim repair. The most common fashion to repair helical rim defects is the Antiabuch technique, which I show you in the next 2 slides. So it consists of a contracutaneous advancement flap of the whole helical rim, but you leave the rear side of the auricle intact. You do not dissect the skin of the rear side. So this gives you a very safe vasculature, and this type of flap really never can become necrotic. However, as I have shown you in the introduction slides on anatomy, we have this helical rim artery which runs all along the helical rim. So you actually can do very long and very narrow contracutaneous advancement flaps without leaving intact the rear side of the ear. You really can cut it to and through and advance the contracutaneous flap to the place where you need it and suture it in, and it gives very safe and nice results also. This is also due to the work of Isaac Zielinski and Stefano Cotofana that we know now by corrosion specimens that this artery really exists. They published that detection or observation in 2015. Our working horse flap, however, is the retroauricular-based interpolation flap. It is extremely safe, and you can repair almost any defect of the helical rim, and it gives you an auricle which is almost completely to the integration completely repaired. It keeps the same size and the same shape, and patients later will be allowed to wear their glasses as before and their ear aids, ear devices as before. We dissect this retroauricular transposition flap that looks like a bridge onto the auricle in a rhomboid fashion, that you have a very large, very broad base compared to the tip of the flap. Then we suture that in and we leave it in place for 3 weeks, which allows for autonomization. That means that you can dissect the pedicle of the flap after 3 weeks, because then the vasculature that comes from the anterior side of the auricle that has connected meanwhile to the tip of the flap is sufficient to give enough blood supply that you can dissect the base. Another elegant way to repair to and through or larger auricle defects are the pull-through flaps. Typically, they are used to repair the conchal ball because they heal in a little bit faster than full-thickness grafts. Here you see a typical example of a pull-through graft. If you would like to read more about this technique, I recommend you the article that I have indicated here, referenced here. It explains you very nicely how to do that technique step by step. You, as I mentioned, can even repair to and through defects where everything, all the 3 layers of the auricle are missing. But you can also repair larger anti-helix defects here. The rear side of the auricle and the cartilage are still here, so you could also apply punch grafts and the graft, but the pull-through technique, the pull-through flap, heals in more quickly. I would like to thank you very much for your attention and would be happy to answer your questions. Thank you very much.
Thank you very much, Jürg. If you have questions regarding his lecture, please comment it on the chat box, and I will give the word to the following speaker. But first of all, I want to introduce him, Christopher J. Miller. He is an associate professor of dermatology and the director of Penn Dermatology Oncology Center at the Hospital of the University of Pennsylvania. The Dermatology Oncology Center provides specialty care for patients with rare, high-risk, or inherited skin cancers. Dr. Miller focuses on advanced Mohs micrographic surgery and reconstructive surgery, particularly for melanomas of the head and neck. His research concentrates on reducing local recurrence and improving reconstruction outcomes for specialty site skin cancers. So, Dr. Miller, please proceed with your lecture about the paramedian forehead flap.
Thank you, Kai, for the invitation, and thank you to the EADV for inviting me. I have no conflicts of interest. The forehead flap is a versatile flap to repair almost any size defect on the nose, usually reserved for larger defects. And in a 10 to 12 minute talk, it's difficult to get into nuance, so I recommend reading these 2 chapters that we have written that go into much greater detail. But as a baseline, a reference for us, if we can do full thickness skin grafts, we make a template, we transfer the template to the donor site, and then we harvest and suture, we can also do a forehead flap because we follow the same 3 steps. Make a template, transfer it to the donor site, and harvest and suture. Grafts, we know, on the nose often have the disadvantages of mismatched color, texture, and volume, or a precarious blood supply. A forehead flap is like a skin graft with an intrinsic blood supply. It's much more reliable, like Dr. Hafner's retroauricular interpolation flap on the ear, and it has usually better color, texture, and volume compared to a graft. So first step, let's make the template. If the defect is near the distal nose, extend the defect all the way to the margin of the nose. A marginal defect is less noticeable. And this is an early case I did where I did not extend it all the way to the margin, and you can see that she has a noticeable horizontal scar. So as an example again of extending all the way to the margin, the marginal scars are imperceptible. Vertical scars are less obvious, so if you're deciding about how wide to make the wound, it's less important. With good contour, a vertical scar usually doesn't stand out as much as a horizontal scar. Match the template to the size of the missing tissue, not to the size of the defect. So in this case, you can see I am the same size distally, but undersized proximally, and we have good contour in the end. On the proximal nose, the skin usually expands. So if you size your template to the size of the defect, you will usually have bulky contour, as this flap does. And on the distal nose, if you undersize the flap, you will compress the nostril. So distal nose, same size, proximal nose, slightly undersized template. Transfer the template to the donor site. The forehead flap is based on the supratrochlear artery, and we have reliable landmarks. The artery usually falls at the corrugator crease or 6 millimeters laterally. So when you make your base of the pedicle go from the corrugator crease to 11 to 14 millimeters laterally, and you're nearly sure to include the supratrochlear artery. Here's a video of this. If you push the forehead together, these vertical creases align with the underlying vessels. The supratrochlear artery emerges 12 millimeters superior to the medial canthal tendon. You can feel the pulse. And then here I'm using a Doppler probe to mark the course of the artery, and you can see it's aligning with this vertical crease. So it's a reliable way to map the course of the artery. If the defect on the nose is on the distal and lateral portion of the nose, position the forehead flap on the same side of the forehead. If the defect is on the proximal part of the nose, but a lateral area, use the contralateral forehead for less torque. So let's look at a video of making the template and then transferring to the forehead. This is a distal defect, so we want the template to match precisely the size of the defect. It's a distal and lateral defect, so we're going to stay on the same side of the forehead. We'll put the template right up to, but not in the hairline, and then our base of our pedicle will be approximately 11 to 14 millimeters wide. You can test to make sure that it reaches with a gauze, and you can be sure then that your template will reach. To avoid the forehead, you can cross the forehead. If you do, the blood supply becomes more difficult to, becomes less reliable. So this is very helpful to make sure that the supratrochlear artery is included with the Doppler. Step 3, we harvest and suture. If we do a 2-stage forehead flap, that means put the flap down and a month later remove it. In order to have good contour, it's best to lift the fat cleanly off the frontalis for the templated portion of the flap. The veins run at the base of the fat, and we want to preserve those. If you don't preserve those, the flap will get congested and look like this. After lifting the templated portion off the frontalis, we will then cut through the frontalis at this transition zone and lift the mid-pedicle deep to the frontalis muscle. So from the surgeon's view, this is what it will look like. Then, as we get to the very base of the pedicle, we will be under the corrugator supercilii muscle, and the artery, the supratrochlear artery, always runs superficial to the corrugator supercilii muscle. So let's look at a video of lifting the flap. This is for a distal flap. So we first are going to lift the templated portion off clean pick of the fat off of the frontalis muscle, you will encounter some of the branches of the supratrochlear and supraorbital nerves. Sharp dissection is necessary. This is not a natural tissue plane. You can see that the blood vessels are superficial there. Now we're going to incise through the frontalis muscle to the loose areolar connective tissue on both sides and get hemostasis. And we will incise through the frontalis muscle and lift the rest of the pedicle deep to the frontalis muscle. We'll continue with sharp dissection until we see the fat pad under the corrugator muscle. Here you can see the fat cells now, and we will transition from sharp dissection to blunt dissection to push the corrugator fibers off the periosteum. We'll try to preserve these veins. You can see the corrugator fibers. You'll sometimes need to release some of the corrugator muscle. Now the flap reaches without tension. To inset the flap, let's look at a video. It's important that the surface area of the flap matches the surface area of the defect. On the ala, it's easy for the flap not to conform to the alar groove. That will usually lead to pin cushioning. So you can see here I'm using 2 tacking sutures to make sure the flap conforms first to the alar groove, and then a typical layered closure with a combination of both deep and superficial sutures. At the margin of the nose, you won't be able to apply any deep sutures, so everything will be top sutures. I prefer a 5-0 chromic gut suture for these, or a 5-0 fast gut. Here's the patient 3 months after surgery. Now, we have to, just like if you harvest a graft, you need to close the donor site, the same with the forehead. Notice that the frontalis muscle is still intact. This is helpful because you may not always be able to close the forehead donor site, and that frontalis will keep the periosteum from desiccating. I like to close from the brow up to the forehead, and only when I'm sure that I can close the forehead completely will I release that for the frontalis muscle. Don't worry about closing the defect. Avoid complex closures on the forehead. They often heal beautifully by second intention. And if it does not heal nicely by second intention, simply stage a reconstruction. 4 to 6 months later, re-excise the spread scar, and you can usually get a nice result. Another example of that with a nice result after a staged reconstruction of the forehead. Last steps. 3 to 4 weeks after the first step, we have to release the pedicle, just like Dr. Hafner's retroauricular interpolation flap. That we follow 3 steps to do this. We first remove the fibrosis from the base of the wound, then remove the fibrosis from the base of the flap, and then finally trim the flap to match the surface area of the freshened wound. Here's the case that we'll look at. Let's start with how to inset the flap on the nose. First, divide the pedicle. I'm using the Q-tip to avoid inadvertently incising the skin on the dorsum. Now we'll lift the flap proximally to expose the proximal defect and freshen the edge by removing about 1 to 2 millimeters of skin and lifting all of the fibrosis off of the perichondrium. Now we can drape the flap and cut it to match the size of the freshened defect. We'll also remove the fibrosis at the base of the forehead flap. Now, I prefer to use a layered reconstruction here with a few buried sutures, then top sutures. You don't necessarily need to have the buried sutures. Let's look at the video of the inset at the brow. Now, if you carry the flap over the superior orbital rim, as I did here, we want to get those brow hairs back up to their natural position. Here you can see the supratrochlear artery. In order to get the brow hairs up, we're going to make an inverted triangle with the peak superiorly right at the edge of the brow. And we have to freshen again the edges at the base and the edges on the flap. We're going to lift the flap to the loose areolar tissue to freshen the base. We have to buzz the supratrochlear artery. And now we'll remove the fibrosis and the reepithelialized skin on the base of the flap. Then the brow hairs will drape without tension, and we can inset the brow by using a layered closure and make sure that we restore the full volume and position of the brow. And then again, we'll use a layered closure after trimming the flap to match. So here's our patient 3 months later, and you can see a nice position and full volume of the brow. So there's a quick survey of the forehead flap. If we're doing full thickness skin grafts by making a template, transferring the template to the donor site, and then harvesting and suturing, we can also do a forehead flap. It's like a skin graft with an intrinsic blood supply and better color, volume, and texture for the forehead. And it will allow us to repair a whole wide range of defects on the nose with great versatility. Thank you very much.
Thank you, Christopher. Very impressive indeed. Paramedian forehead flap is a very nice reconstructive movement. It is mainly used right now in the United States by dermatologists and not so often somewhere else, but we will hopefully have a good discussion on this at the end of our webinar today. So I will, if you have any questions, please comment it on the chat box. And I don't know if the last speaker is already in. Okay, very well. Marlies. As last speaker, I can introduce my colleague Marlies Wakee from the Erasmus Medical Center, which is still the biggest center in Mohs Micrographic surgery in the Netherlands and probably in whole Europe. Marlies Wakee is an associate professor and works as dermatologist at the Erasmus MC Cancer Institute, where she leads the dermato-oncological unit and is responsible for complex dermato-oncological cases that often require advanced surgery and multidisciplinary care. After finishing her training in Mohs surgery in 2015, she has further subspecialized into periocular Mohs surgery. She described the outcome of over 700 periocular Mohs procedures in the British Journal of Dermatology in 2019. So, Marlies, please proceed with your lecture on periocular reconstructions.
Thank you very much, Kai. Thank you for the introduction. So go ahead. Well, I don't have any conflicts of interest related to this presentation. So let's start with the first patient. So this patient has a basal carcinoma on the lower eyelid, and I think especially on the eyelid, Mohs is a really good indication for treatment. And usually you might think to make your first wedge excision like this. And I think I try to make all kinds of small tips in my presentation. So what is important when you perform a wedge excision is that you try to make your cuts on the lower eyelid line perpendicular to the eyelid. So this way, when you perform your reconstruction, you don't get any notching and the eyelid is a little bit everted and pulled upward. So then I've made some pictures for the reconstruction. So when the patient is free of the basal carcinoma after you've checked your slides with frozen histology, then we put in our stitches, and I like to work with Vicryl 6-0 sutures. And I've put in this drawing of the anatomy of the eyelid because it's important to realize that when you reconstruct a full thickness defect on the eyelid, you close it in 2 layers. So the most important relevant layer is the deepest layer. So this is where this is the tarsal plate which really pulls the eyelid together. And then the second layer is the layer of the skin and some subcutaneous tissue. So here you can see how I position my sutures. And the other thing, what is different from any other suturing, is that the knots are, you make them superficial. So normally you would tie the knots deep, but then in this case you have a risk of perforating the cornea or getting any problems in that situation. So what I usually do is first put in my two sutures. So here's the first one. And I also like to just demonstrate a little bit about the instruments that I really like to use when performing Mohs surgery around the eye, because I think it's important to have some good instruments like a good needle holder, a smaller forceps, and I also like to work with some magnifying glasses, which magnifies your vision by 2.5 times. So here you can see I've put in the two stitches and I put them in both first before I tie my knot, so I can really see that it's well positioned. So this way I'm sure, and I can test if the eyelid really comes together nicely, as you can see in the second slide. So then I make my knots. And then I only do one knot at the lower part as well. But as you can see, the two sutures through the tarsal plate are the most important when you make this reconstruction. So after that, I put in my transcutaneous sutures, and for this I usually use a Prolene 6.0 suture. And what you can see is that I've tried to make pictures of it, is that I try to suture to knot every suture down with the next suture. So I make one knot, and then I put in the previous suture, and then I tie over that my next knot, so that the sutures will not bother the patients during the week, and the suture, of course, isn't buried in the wound bed. So here you can see the result just 1 week after. Here you can see another patient where we performed the same procedure, and you can see the results just 1 week after removing the stitches and a few weeks later. And usually this heals really well, and you hardly see any scar tissue. So here's another patient with a basal carcinoma on the lower eyelid. And I think what's really nice of performing Mohs surgery is that we can really be tissue sparing. So in this patient, we didn't see any tumor on the conjunctiva part of the eyelid. So then in that case, you can make an incision on the gray line. So the gray line is the line where the skin passes over into the conjunctiva. And I usually like to work with a blade 11 because it has a nice sharp tip, and you can make your incision on the gray line, and this way the tarsus remains in place, and you only remove the skin and the subcutis over there. So here you can see the result after the Mohs round. So you can see that the second part of the eyelid is the dorsal part of the eyelid is still present. So, and for the reconstruction, I think a Tripier flap is a really nice reconstruction in these kind of defects. So I make my incision on the upper eyelid, and I then transpose this to the lower eyelid, and I remove a little bit of the lateral part of the eyelid. But if the defect would be more to the medial side, then I would leave the skin, the remaining skin in, and I just cut the flap at a later time. And I made for the lower part of the reconstruction, excuse me. And for I use some single sutures for the lower part of the reconstruction, and the sutures that are near the eyelid margin, I use a running suture. So this way, there are no sutures that are bothering the patients during the week with the sutures. And again, you can see the result really nice after a few. It's really nice after a few weeks. So well, Going to a little bit bigger defect. So this patient also had a basal cell carcinoma, and I've removed approximately half of the eyelid, but still quite some part of the tarsus is still present. So this we can use for the reconstruction. So what's really helpful in that case is to make a semicircular tensile flap, and we make our incision from the lateral canthus until the orbital rim. And I also make my cut rather deep, so I also include some muscle tissue to really give it also some, to make sure it's really vascularized and has some volume. So here you can see after making the incision in the skin, I also perform a cantotomy and a cantolysis, where I free the lower eyelid from the lateral tendon. And this way I can move the eyelid towards the medial canthus. And then the stitching of the medial canthus will be just as any other wedge excision. And then the lateral part of the lower eyelid, you have to refixate it to the orbital rim again. So I fixate it to the periosteum of the orbital rim. And I fixate this a little bit higher, because usually the eyelid sags a little bit during time. So here you can see the result directly after the reconstruction, and already after 1 week it looks really nice. So if the defect is even bigger, then my preferred reconstruction is the huge tarsoconjunctival flap. The disadvantage, of course, of doing a huge tarsoconjunctival flap is that the eye is closed for approximately 2 weeks. So the patient has to have a good other eye, otherwise the patient will be blind for 2 weeks. So in case you perform a huge tarsoconjunctival flap, again, you reconstruct your defect in 2 layers. So for the skin layer, I usually take a graft from the same eyelid, from the upper eyelid. And it's important when you measure a graft that, especially around the eyelid, that the red arrow, so the length of your graft, is really accurate, or even a little bit bigger than what you measure, because if there's any shrinkage in this direction, you have a risk of developing aniectropion. So for any graft you do around the eyelid, make sure your length is okay. Then the black arrow, so the width can be a little bit smaller, because that pulls the skin together. So here you can see the result after we've taken the graft from the upper eyelid. And then we continue by reconstructing the lamella of the back of the conjunctiva. So we invert the eyelid, and for this I like to use a Demar retractor, and then I make an incision and you can nicely see the tarsal plate exposed, and I make my incision and I leave approximately 2 to 3 millimeters of the tarsus. I leave it in place. After making here you can see the drawing of the flap, and here you can see that is already cut, and then I dissect I make my dissection on the tarsal plate until the cranial part of the tarsal plate, and then I can stitch the tarsus into place where I connect it to the remaining part of the tarsus, as you can see over here. And also I make 2 sutures connected to where I connect the conjunctiva of the lower eyelid to the conjunctiva of the tarsoconjunctival flap. Then I put in, if these sutures are all into position, then I suture in my graft. And there are 2 important sutures also to position there. And these are the most superficial sutures, where I attach the graft very superficially to the tarsoconjunctival flap. But it's important to not perforate it, of course, because in that case you can get cornea erosion. So here you can see the results just 1 week after removing the stitches. And then after 2 weeks, we cut the huge flap, and then you can see the results a few months later. And I think the result is really nice, and also results in a nice and firm eyelid again. So here another patient, and again you can see the results just directly after positioning all the sutures, and then 1 year later you can see the final result. So what if you can't do a huge tarsoconjunctival flap because, well, for example, in this patient, this was her only good eye, so we would make her blind if we would close the eye for 2 weeks. In her case, we decided to do a free tarsoconjunctival graft with a myocutaneous transposition flap. So we just turn it around. So at first, we take the tarsoconjunctival flap from the upper eyelid, and instead of leaving it connected, now we just suture this into position, and then we transpose with bilaterally vascularized the skin and the muscle of the upper eyelid to the lower eyelid. And again, when you make your sutures at the eyelid margin, make sure that these are running sutures so the patient isn't bothered by the sutures. And so here you can see the result just 1 week after removing the sutures, and we leave the connection to the upper eyelid still present for, well, a few more weeks, because it's really important that it's just well vascularized and there's not much shrinkage of the tissue. So then after another 3 to 4 weeks, the flap is cut, and here you can see the result just directly after removing after putting in the sutures, and here you can, in the lower picture, you can see the result after a few months. So I think this is also a really nice result of a reconstruction. So this is my short presentation on some periocular reconstructions, and I know that the application deadline is already closed for this year, but every year we train 2 Mohs fellows through the EADV. So if you're interested, please look at the EADV website, and you can apply for this Mohs fellowship if you're interested. Thank you for your attention.
Thank you, Marlies. Thank you, Marlies. Impressive. Impressive lecture. I think we will have the questions later on. And again, if you have any questions regarding the lecture, please comment it on the chat box. Ladies and gentlemen, it was a great honor to have you participating in this course about Mohs micrographic surgery and reconstructive surgery. Dear Dr. Wakee, Dr. Hafner, and Dr. Miller, thank you for your excellent lectures. Just let me point out that all the speakers today were experienced Mohs surgeons, and this is the reason why we have to promote Mohs surgery more in dermatology. Because without Mohs surgery, there will be almost no reconstructive surgery performed by dermatologists, which is still the case in a lot of European countries and countries around the world. For this case, we must look at the United States of America as shining example. For my part, we still have a lot of international fellows. Marlies already mentioned, from Scandinavian countries, England, Ireland, and at this moment we have a fellow from Paris, France. For the closing remarks, I will give the word to Christopher Horskamp at the EADV headquarters in Lugano. Christopher?
Actually, before we move on, we have a couple questions from the audience. Would we like to go through them right now?
Of course.
Great. I'll pull one up on the screen right now, and it's about tactics. What would be the tactic if a person has multiple facial malignant lesions? Would you excise, reconstruct as many lesions at once, or is it too much stress for a person and the surgeon?
You can, of course, treat 3 or more lesions in one session. We sometimes do it, but you can. It's We perform also sometimes two basal carcinomas in the face, sometimes even 3 with micrographic surgery. So both is possible. But if you have a lot of tumors, normally we do not perform more surgery than on 3 or 4 tumors. I don't know what is the experience of the other speakers. Marlies, Christopher?
Yeah, well, perhaps I can respond to that. So I think it's important to realize when you have patients with multiple facial malignant lesions is that you still make sort of a plan also for the reconstruction. So if you think that 2 lesions are closely to each other, then they might bother each other with the reconstruction. So once the stitches are pulling each other in the wrong direction, so then you might decide to first do one and then the second one. So sometimes for me, this is a way to split it up, but usually you can do 2 or 3 at the same time.
I try not to do too many at one time, but when I have to, I try to stage local anesthesia, because this is actually the most stressful moment for the patient mentally and also for his pulse. So sometimes we have to treat elderly patients around their 90s with 6, 8, 10 skin tumors, and we see them only once. It's a kind of palliative oncologic surgery. There I tend to stage local anesthesia, not all the 10 lesions at one, but I do 2 local anesthesias and remove the tumors and so on, stepwise. So it is like tumescent technique, and I dilute local anesthesia to 0.5 and to 0.25% of lidocaine. So I never have any intoxication or any tachycardia, no vagal reactions, and so on. This is actually what I fear more than surgery itself. And in these kind of palliative oncologic surgical situations, I do not always go for complete repair, but I also apply purse string suture closures, partial closures, just to keep the stress for this elderly patient tolerable.
Yeah. And perhaps, and sometimes you can also decide which tumors you think the patient will be bothered by the earliest. So if you have a tumor, of course, from my perspective, a tumor near the eye and one on the cheek, I would prefer, of course, to first remove the tumor around the eye, because you would expect the most problems of the tumors that are situated on this location.
Okay, Christopher, other questions?
Yes, actually, we have another question from the same attendant, and it is, if the lesion grows into the muscle, would you reconstruct it with a big muscle defect, for example, on the forehead? Not sure if I read that correctly, but see if we can.
Yes. Normally, if it grows into the muscle on the forehead or on the scalp, it will be no problem, because we excise often under the gallia, which is directly on the periosteum, and you can, this is a natural area where almost no bleeding occurs, and you can have a lot of tension, especially on the gallia, to closure the defects, if you want to. That's my experience. I don't know what the other
It doesn't change. Actually, it doesn't change anything. You just absolutely have to make sure that you have removed all tumor. Even if it reaches periosteum, you will remove periosteum. If it goes beyond periosteum, you remove bone. You just really have to remove everything. You shouldn't repair before that. Actually, you can repair almost any defect. We don't mind if the muscle is infiltrated or not. Something you can do if you are a beginner dermatologic surgeon is that you send us pictures and we try to give you a good answer as fast as possible.
And of course, everything will heal by secondary intention. So every wound will close automatically.
Except for leg ulcers.
I think we have time for one more question, if I can jump in. And we actually have a question from a member who says, thank you for your excellent talk. What is your anesthesia preference for the paramedian flap? And do you perform the tumescent anesthesia or neuroblocks?
The forehead flap is one of the easier flaps to anesthetize the patient. You know, lidocaine in the US, you can get in bottles with 1% lidocaine and 1 to 100,000 epinephrine. We use 0.5% lidocaine and 1 to 200,000 epinephrine. But you can do discrete nerve blocks on the nose. You can block the infraorbital nerve, the anterior ethmoidal branch of the nasociliary nerve, and you have almost the entire nose anesthetized. And on the forehead, the supratrochlear nerve and the supraorbital nerve. So you can do if you're doing bilateral injections, you can just do a few injections and you have the entire central face, forehead, and nose numbed up. So anesthesia is rarely a problem for volume on patients. The procedure takes longer, so intraoperatively you may want to re-anesthetize to keep it fresh.
Nerve blocks is certainly a very elegant manner to anesthetize, and it's mainly less painful than local infiltration. Of course, I know from Professor Hafner that bicarbonate is very important. So it's certainly less painful, and we do it with every operation right now. Christopher, some other questions?
We have one last question, and it is from, let's see, it's on the screen right now. Hello to everyone. My question, what is the super advantage of Mohs surgery in comparison to removing all lesions with the best safety margin?
Yes, first of all, as I have mentioned earlier, with conventional surgery, you never know if you completely excise the tumor, and especially you see it very well with tumors like dermatofibrosarcoma protuberans, where you couldn't see the margins of the tumor, and you could see it only under the microscope. And we excise with small margin, but we excise completely. And this is shown, the advantage is shown for basal cell carcinoma, for squamous cell carcinoma, for dermatofibrosarcoma protuberans, almost for every tumors. We excise even Merkel cell carcinoma of the face with micrographic surgery, which will have no better outcome for the patient, but we have less to excise, so we are very tissue sparing in these cases. Christopher and Marlies, have Jürg something to add to this?
I would just describe another way of describing Mohs surgery as precision surgery. One advantage, a way of thinking about it, is that your defect conforms to the shape of the cancer, not to a cookie cutter template of how wide a margin to take. And Kai, the example you showed on the chin earlier today was a very nice one of how if you used a cookie cutter template, you would not have likely achieved a clear margin on that. You mapped that tumor in both its breadth, how wide to cut, and its depth, how deep to cut. and the microscopic directed excision is the super advantage. You knew where you needed to go.
Yeah. And perhaps to add to that, you can just spare important parts of the face especially. So you can spare the lacrimal duct, or you can make your reconstruction smaller. So it's also beneficial for the patient.
Yes.
I think those are all the questions.
Perhaps another answer is, if you work at a place where you don't have Mohs surgery, you can apply slow Mohs surgery. You can go for excisions with marked margins and put them to formalin. And as Kai Munte mentioned, you can get the results after less than 24 hours. So you can leave the defect open if the patient does not live too far away, and just keep the wound moist. Or if you don't have to perform flap surgery, you can close the wound if it's just spindle shape or purse string suture, and take the patient in and do more resections as necessary. So you can also check on formalin fixed exudates, excisional samples, if the margins are free. This is just an answer because I imagine that not all our attendees have the possibility to exert Mohs surgery with fresh frozen technique. So you can do it on formalin too. It's slow Mohs, the so-called Tübingen technique of Helmut Bräuninger and his team.
3D histopathology, he called it. Yes.
And I mean, there is good scientific work that shows that recurrent rates are definitely lower when you apply Mohs surgery or the Tübingen technique, slow Mohs surgery, compared to using a cookie cut standard safety margins. Standard safety margins are not bad at all, but they are a little inferior to margin controlled surgery, either on formalin or on fresh frozen tissue.
Yes, I totally agree. Yeah. Thank you very much for your excellent lectures. Thank you very much, Christopher. I will give the closing remarks to Christopher Horstkamp at the EADV headquarters in Lugano.
Well, thank you very much. We would like to give a special thank you to Dr. Munte, Professor Hafner, Professor Miller, and Professor Wakee for their engaging presentations today. And on behalf of the EADV, thank you for joining us and sharing your thoughts and questions with us. Now, the EADV is proud to offer numerous opportunities to stay on top of the state of the art in all things dermatology and venereology related. There has been an extension for abstract submissions for the EADV Congress this fall. Submit your abstracts by the 25th of May on www.eadvcongress2021.org. Did you know that we're launching a sister journal to the JEADV? It'll be called JEADV Clinical Practice, and we are inviting you to submit nominations for the editor-in-chief position by the 9th of June. Also on the 9th of June, we'll have our next podcast, an update on non-invasive technique for melanoma and non-melanoma skin cancer. Now, the EADV is constantly offering new webcasts and podcasts. This webcast will be permanently available for EADV members on the EADV e-learning platform. At any time, you can also check out the Dermatology Podcast, EADV's official podcast, available on all major podcast platforms, including Apple and Spotify. Don't forget to follow or subscribe. Thank you again for joining us, and have a pleasant day.